This is the main speaker? No, there.
Okay, hello everyone. We are just waiting a minute or so for folks to join us. Thank you so much for being here today. And I'll get started in just a minute as people log in and join us. Okay, welcome everyone. Hello and welcome to the Collaborative Center for Climate and Health seminar series. This is a brief introduction. I'll just briefly introduce myself and then provide an overview of the series. My name is Karen Bourne. I'm very happy to very briefly open up today and to introduce the center as well as our speaker and our moderator. So let me first briefly introduce the Collaborative Center. For those who are joining us for the first time, the Collaborative Center was launched in November of 2023. It is an initiative of 4 faculties at the University of Toronto, the Dalla Lana School of Public Health, the Temerty Faculty of Medicine, the Lawrence Bloomberg Faculty of Nursing, and the Leslie Dan Faculty of Pharmacy. The Collaborative Center's purpose is to catalyze climate and sustainability action for health and health systems through research, education, practice, and policy change. So you see us here today. We are at the Dalla Lana School of Public Health with our speaker, our moderator, and some members of the Collaborative Center. So before we get started, I'd like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. I recognize that this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and learn on this land. Today's event is titled Sustainable Healthcare, where Healthcare and Climate Change Intersect, and very pleased to have Dr. John Bonning here, who I will introduce shortly, as well as Dr. Wendy Levinson, who will moderate. Dr. Bonning will present for about the first 30 to 40 minutes of our time together today, and then we'll have the remainder of the hour for question and answer. So first, I will introduce Dr. Bonning, who is a specialist in emergency medicine, who's practiced for 35 years out of the Waikato province of New Zealand and occasionally the outback of Australia. Dr. Bonning has held a number of leadership roles across Australia and New Zealand, culminating in a term as the president of the ACEM, which is the Australian College of Emergency Medicine across the pandemic. During that time, he was chair of the Council of Medical College of Presidents of New Zealand and on the board of the International Federation of Emergency Medicine. I personally have had the privilege of collaborating with Dr. Bonning in his leadership role of Choosing Wisely New Zealand and collaborating with him through the Choosing Wisely International Collaboration and Learning Community. Dr. Bonning is a passionate advocate for fair and equitable use of healthcare resources, and now his work is focused on equity and achieving the triple sustainability aim of personal, professional, and planetary goals. And he is currently in Toronto as part of a 4-month international sabbatical on sustainable healthcare. So we're very happy to welcome John here. I would like to next introduce Dr. Wendy Levinson, who will be our moderator. For those who are joining from the Choosing Wisely community, Dr. Levinson really needs no introductions, but for those who are joining from the Collaborative Center community, Dr. Levinson serves as chair of Choosing Wisely Canada and has done so for the last decade. Dr. Levinson also serves as chair of Choosing Wisely International and is a professor of medicine at the University of Toronto. So now I will hand it over to John.
And just one last thing, feel free to put questions in the chat or throughout the talk. We don't have to, we can stop as needed to answer or have your comments. So just either put your hand up or put your comment in the chat box. Over to you, John.
Fantastic. Thank you very much. Thank you very much indeed, Karen and Wendy, for your kind introductions. Yeah, we have known each other for a number of years. There's been a bit of a gap as I have, unfortunately, the pandemic kind of shut down travel a little bit. And it's wonderful to be back here in your beautiful country in Canada. And I would also acknowledge the Indigenous owners of the land which we're speaking on today. something that I think is deeply important to do. So thank you very much for the invitation to come and speak to you today about something that I'm deeply, deeply passionate about, and that's sustainability. And kind of, as you've heard in my bio, a triple aim of sustainable for the people or population of health for healthcare, but also of the planet. And I'm just starting a sabbatical. I'm moving from here briefly to the US and then on to Europe to investigate, listen, learn about sustainability in healthcare and planetary healthcare, and looking at the impact of healthcare on climate. And illustrate a little bit of my world down under, as it were, from Australia and New Zealand. So I live and work in New Zealand, tiny little island, a long way away, although there is a nice direct flight to Vancouver now, which is good. Canada's population, 40 million, is nearly 8 times New Zealand's population. Your 10 million square kilometres means that 37 New Zealands would fit into Canada, so we're a little bit smaller. Australia, I did half my training there. I was president of the college across both countries. I spent a lot of time there. I do locums right in the very, very red centre of Australia, in a place called Alice Springs, which is a beautiful place full of a lot of Indigenous people and tens of thousands of years of culture. So I kind of sit across both countries. Sometimes people think that the Harbour Bridge in Auckland and Sydney are connected, but they are in fact not. So thank you very much for the invitation to come and speak to you today. As Wendy said, I welcome questions, queries in the chat. A 40-minute monologue from me would, I think, send most of you to sleep, but yeah, look forward to some discussion of some of the issues that I'm going to talk about. Next slide, please. So these pictures familiar to some of you, any of you with Choosing Wisely experience, and of course you'll see Wendy and Karen, I believe, in most of those pictures. Choosing Wisely, Canada, clearly world leaders in this front. Australia was launched in 2015 and New Zealand in 2016. There was an earlier launch in the US, but arguably I think it's fallen over there and they need to change more than perhaps anybody else. And it's about rationalising, not rationing of tests, treatments and procedures, a clinician-led consumer focus. These are all things that you know, quality healthcare involving clinicians, consumers and educators, and a reduction in over-testing, over-diagnosing and reinvestment of that. So the pictures there is from Amsterdam in 2017, Zurich in 2018 and Berlin in 2019. And it was in Berlin in 2019 that Kaveh Shajania, who is from the University of Toronto here in Berlin, was the first time that I heard the co-badging of Choosing Wisely with climate advocacy. And of course, that's built substantially since then. And of course, this is even more pressing now on many fronts. So I'm not necessarily a dyed-in-the-wool greenie, as most people might think of people. However, I'm really passionate about both equity, which I'll talk to, that fairness of healthcare delivery and sustainability, and it has some really important green side effects. And of course, we really do need to save the planet as well as healthcare. Next slide, please. So what happened to Choosing Wisely in New Zealand and Australia? So 11 years, I believe, very strong here in Canada. It's now very mature, looking at sort of firming up the international relationships. In New Zealand, it was initially run by the Council of Medical Presidents across all the medical colleges, but then on a shoestring budget, and then was subsumed into the Health Quality and Safety Commission, from where, unfortunately, it appears to possibly have disappeared without a trace. When you go to their website, there's some Choosing Wisely links there, but they said that this information is not being actively updated and hasn't been done so since 2021. There's a few of us that were really passionate about this, myself, Derek Sherwood, an ophthalmologist, Sue Ineson, and we've since had to sort of move on with other things, but I'm keen to revisit this. And unfortunately, choosingwisely.org.nz is now a defunct website. So it's kind of fallen on dead ears, which is a bit of a shame, but let's see if we can rejuvenate it. So in Australia, it was also taken over by the Australian Commission on Safety and Quality in Healthcare and rebranded as Better Care Everywhere. A colleague of mine, an emergency physician from central New South Wales coast, works for the Commission, and she said the Better Care Everywhere is kind of branded a little bit as Choosing Wisely 2.0. And you go to their website and it says Choosing Wisely played an important role in initiating a national dialogue of reducing unnecessary TTPs, test treatments, procedures, laying foundations for a broader system approach that can consolidate and extend the benefits of reducing low-value care. After careful consideration, the Commission will retain ownership of Choosing Wisely Australia, that used to be run by NPA Medicine Wise, but its recommendations and resources will not be updated. So again, kind of dead in the water a little bit. And they wanted to move a little bit more from a do not do list of low and high value care, depends very much on the patient. And you'll see here from the slide there that the Choosing Wisely FAQs and the most downloaded resources are still there. And it's still aimed at reducing unwarranted clinical variation and reducing the risk of harm. For example, if you go in there and look at antibiotic stewardship, there'll be a clinical care standard. Wouldn't we want to be part of that international community that the Canadians are so good at leading? So it's a little bit of sad news for where Choosing Wisely is, but I think we can come back and rejoin the international community, and that's what I'm hoping to try and learn and drive from. Next slide, please. So, what do you care about? How's healthcare doing in general? We've got tons of resource, tons of money. Everything we do adds value. There's no waste. Yes, a few chortles in the room. Not quite so. So I often like to talk about levers that make people shift their opinions and practice and care about saving healthcare and the planet at the same time. Everyone has different levers that will shift them, and perhaps I do want to scare people a little bit. I often say we want to scare people, but don't scare people, because otherwise it puts them off. And so I'm looking for what motivates you, what your levers, what's going to make you shift in your thinking. And hopefully I'm speaking to the converted. From talking to Wendy over the last few days, it sounds like this is well embedded in your health system and almost more importantly in the medical school curricula, as being something that's really critically important. So what do you care about? Equality, treating everyone equally well. There's something to be said about that. But then there's equity, which I think is slightly more important: cultural, gender, resource equity, understanding that people don't come from the same social and economic standing. And there I've got Maslow's hierarchy of needs saying that it's obviously quite challenging to care about anything else when your physiological and safety needs are not being met. Do you care about your family, your friends? I would assume so. Geopolitics in China, Russia, Europe, and south of your border with the president who shall not be named, and the conflicts in Ukraine and Gaza. They're very hard to ignore, and they're real prescient things right up on in our faces at the moment. But do you care about our future? I hope so. And so, and of course, the caring about the healthcare and sustainability of our planet and future generations. Next slide, please. So you'll all know the 3 R's of Choosing Wisely: rationalising, not rationing of resources for patients with little chance of benefit, and responsible resource stewardship to all of our patients and communities for the care that they really need, then reinvestment of that resource to those with a chance of benefit. So the equity issue is something that's really important. So it's really important that some populations will, say, for example, need less antibiotics for their viral pharyngitis. but post-streptococcal rheumatic fever and glomerular nephritis still exists in Indigenous populations in Indigenous Māori in New Zealand, Aboriginal Torres Strait Islander peoples of Australia, and Pacific peoples. So some populations need less screening for diabetes, cardiovascular disease, lung, breast cancer, but some need more. And again, there's so much unnecessary care, and I'm talking a little bit about that later on, unnecessary antibiotics, just touched on CT scans, blood tests, etc. So, but we do need to couch the message differently to different populations depending on their exposure to the social determinants of poor health. And this is what the Australians are talked to when they're talking about better care everywhere for everyone. So making sure that the choosing wisely messages are nuanced. Next slide, please. So here's what I think should be our new AAA, and again, hopefully this is not news to all of you, of the 3 PEs, the best possible outcomes for people, and that's equity, and more on this issue shortly, but resource stewardship, more for those who need it, who will benefit and not be harmed. Profit is in there, it's just the cost of healthcare, the economy, and the words used for convenience is not about profit per se, and then the planet and the environment in which we live. And we all know that that's a really major issue. Next slide, please. So this is just a little bit of what our college has done over the years. In November 2019, I had the privilege of being inaugurated as the college's 12th president and the first from New Zealand. Seems like a lifetime ago, pre-pandemic. And we were the first Australasian college to declare a climate emergency. And I said on that day, the evidence is clear. Projections show that climate change will cause a significant rise in the number of overall ED presentations, an increase in the complexity of presentations, as well as surges resulting in climate disasters, with research also showing that climate change will exacerbate existing health inequities. And we have an obligation and responsibility as emergency doctors to speak up and to take action ourselves and demand action from the government. So first time ever, walking in the streets with placards for a really good cause, and it kind of set off a bit of a wave of such protests in Australia and New Zealand. So that was 2019, and then soon after, being in Hobart down in Tasmania, South Australia. Next slide, please. I went to Sydney for a conference on overdiagnosis, a conference I'm again going to in September of this year in Oxford, run by Oxford University. But the Victorian and New South Wales bushfires of the summer of 2019 and 2020, and I believe here in Canada you've been afflicted by bushfires as well in places like the Okanagan. And these were really significant fires in 2019, 2020. 5.6 million hectares of rainforest in the southeast destroyed, 25 people directly killed by the fires, but a reality, the toll of greater than 400 deaths. Smoke-related health cost of nearly $2 billion, 2,500 homes destroyed in one of the biggest wildlife catastrophes in history, with 3 billion animals either displaced or dead. And smoke affected both a third of Australia and significantly 2,000 kilometres across the Tasman. You can see on that picture, we had glacial discoloration as a measurable increase in snow and glacial melts as the clouds came over and turned our snow orange. And in the bottom left there, you see a picture of Sydney, what I call the sepia Sydney picture. That's a photograph I took on a harbour cruise at that overdiagnosis conference. This is the middle of the day, and that's looking at the sun in the top of the picture, and ash was falling on us like snowflakes. So the cost of climate change impacts is going to be measured in the trillions, and one report suggests an annual cost of 1.9 trillion, or 4% of the GDP in Australia. So this is real. Next slide, please. And just briefly, again, some of the things our college has done. The College of Emergency Physicians, we're shifting our investments to more responsible banks and those that don't invest in fossil fuels. Got environmental strategies, sustainability action groups, SEMCAN, Sustainable Emergency Medicine and Climate Advocacy Network, has been formed. I'm on the executive of that. And we're trying to get sustainability. Our college foundation, the charitable arm of our college, has Indigenous health global healthcare and research as three pillars of that foundation. We're trying to have sustainability introduced as a fourth pillar. Next slide, please. So just these two documents talking about, again, the climate impact the street of healthcare and sustainable practice in EDs. Next slide, please. So climate change and healthcare, of course, intimately related, as you all know, in both directions. Climate impacts healthcare and healthcare impacts climate. And we're going to talk a little bit more about that just now. Next slide, please. So here's a sort of a pictorial look at the climate impact of climate change on human health. So you've got extreme weather events. We've touched on fires and cyclones and floods. And I believe there's a significant tornado season going on in the east coast of the US at the moment. Heat waves, rendering parts of the world too hot to live, and heat illness and death, particularly vulnerable populations, being a real issue. Wildfires, droughts, storms, more rainfall causing flooding and landslides, ice melt. So sea levels rising 1.5 to 2 meters, again affecting the vulnerable populations, in particular in our part of the world, the low-lying Pacific Islands, some of whom will go completely underwater with that sort of sea level rise. Forced displacement and migration, climate refugees, and changing in distribution. I just saw one of the questions coming up talking about regeneration, and that's certainly something I think we should talk about in due course. I'll just quickly finish this slide discussion. Change in the distribution of vector-borne diseases, ticks, mosquitoes, malaria, dengue, Lyme, chikungunya, occurring in more temperate zones. Air pollution causing asthma, allergy, cardiovascular disease, water quality and supply issues, and the spread of cholera, campylobacter, and harmful algal blooms. And of course, the mental health impacts. And of course, we're seeing enormous increased surge in mental health impacts. Do we want to sort of
Sure. I mean, actually,
discuss?
I mean, there's a comment a few people liked to say, you know, they can relate to the orange sky because it looked like that in Edmonton.
Yep.
And, you know, this is becoming an unfortunate sky
Yep.
in many parts of the world. But do you want to address the issue that David Berman's brought up about should we not be talking about regeneration rather than sustainability?
Indeed, sustainability implies kind of, you know, trying to keep a status quo. Regeneration is that next step on, is it not? Where you are looking to improve and not just trying to keep the status quo in these things we're talking about in healthcare environment, and actually be meaningfully positive. And you're absolutely right. It's part of that journey from where we're kind of, and there's a good picture I've seen where we're kind of in the stage of sustainability over on the left, and you're just trying to claw back to, you know, to something more positive. But regeneration is being more positive and proactive and building better hospitals and you know, the Choosing Wisely campaign in healthcare. So I do agree that the term regeneration is really, really powerful and positive. I'm not sure if anybody else in the room has anything to offer on that, but yeah, that is a much more proactive and positive. I don't know if David wants to put any comments about what he sees regeneration to be, or wants to speak to that, but absolutely that's a more positive regenerative mindset as opposed to just keeping that status quo. Yeah, sustainable leading to collapse. So yeah, I do agree with that indeed, and perhaps we'll have more of a discussion of that maybe at the end of the talk. Next slide, please. So to the impact of healthcare on healthcare delivery on climate. So if healthcare was a country, it would be the 5th greatest country in the world, with about 5% of global carbon emissions, behind China, US, India, and Russia. Although Australia quotes 7% of their carbon footprint being due to healthcare. And there's a bunch of different pie charts you can find on this. So looking at supply chain, including production of medical supplies, being a big chunk, nearly 2/3. That's the blue segment there. Manufacturing and distribution of pharmaceuticals and medical equipment. And Wendy was telling me yesterday she has a slide showing the life of a pill, which is very, very interesting in terms of its manufacture, delivery, use, wastage, etc., etc. but also business services, other procurement, food and catering, of course, which is a huge amount of waste in. So healthcare delivery felt to be around a quarter of the total footprint of healthcare, and the generation of huge volumes of medical waste, including plastic packaging, single-use medical devices, instruments, gloves, PPE. I've got some slides on that shortly. Surgical drapes, contributing to landfill waste and potential harmful emissions during their disposal, and of course anaesthetic gases. There's a significant move away from desflurane. We're trying to dereticulate nitrous. It's just unbelievable that places with reticulated piped nitrous in their hospitals lose 90% of it to the environment without it being even used. So we must dereticulate nitrous oxide, and anaesthetists, I believe, are leading in this. To energy use, hospitals and healthcare facilities consume large amounts of energy in the operations like lighting, heating, ventilation, medical equipment, often relying on fossil fuels, which produce significant carbon emissions. Medical waste, and we're going to talk a little bit about futile and unnecessary or harmful care shortly. Transportation, so patient transport, staff commuting, delivery of medical supplies, or generating admissions. And vehicles relying on fossil fuels. I'm lucky that I can ride my bike to and from work. We don't have very good public transport, unfortunately, in New Zealand. Car parks are often full, and you have patients turning up to their clinic appointments, driving around the hospital trying to find a car park, and then driving home again because they haven't been able to find a car park. Obviously, in the larger cities here, you have much better public transport, but mass transport and bicycles need to be one of the ways forward. And then building construction and maintenance. The construction and maintenance of healthcare facilities requires significant energy and resources, contributing to the carbon footprint. So I just visited Australia, and the John Hunter Hospital in central New South Wales has just built an entirely new block. And again, hopefully on these regenerative principles, with very, very strong emphasis on use of natural light, green spaces, and trying to make, as you were, green aspects in the entire build, which was expensive, but I think it's something we can't afford not to, rather than just build more buildings. Next slide, please. So this is a more complex look at the interaction of healthcare and climate. Across the top, you've got medical and mental health impacts, including heat-related illness, evacuation caused by climate, trauma, anxiety, PTSD, asthma and COPD, infection including vector-borne illnesses, malnutrition, and forced migration. Then on the left there, you have the impact of health, both individual and systems impact, and then the social and economic determinants of poor health. I've always suggested that healthcare has clinical, psychological and social aspects in each individual, and they're all quite important. Sometimes we only think about the kind of clinical aspects when psychological and social are very, very important. And then along the bottom there, you've got the direct environmental impacts of weather extremes, habitat, biodiversity loss, soil loss, water shortages, and the global temperature rising and sea level rising. So what can we do? What are our levers? What are your levers? What are you going to do differently tomorrow? What are you doing differently all the time? And you may well be doing a lot of these things. So I'm an emergency physician. So these are my levers. These are our levers. And I think that we can stop the waste, and we can stop this futile and unnecessary care. And I'm truly passionate about rational care, and the choosing wisely in the equity of healthcare delivery and reducing the harm of healthcare. So amongst my colleagues, the junior doctors I work with and the nursing staff and my emergency department, and in fact, amongst my friends, I'm often known as Dr. No from the James Bond genre, because they always come to me, so I do this test, no, and I just automatically say no, and then we turn around and talk about things, and I'll talk about a little bit few of the things that I'm trying to campaign to do less of and stop. because we've got lots of inefficiency in our crowded emergency departments, and they contribute to that significant healthcare expenditure and wastage. But these unnecessary things impact not only the patient, but also the environment and to healthcare delivery of the whole population. So you could say, don't just do something, stand there when you're standing beside a patient thinking of what the next test, treatment or procedure that you might want to perform. So we need to stop doing, giving, performing unnecessary IV lines if they don't need the IV line for medical fluids. And of course, that campaign could be called One Less Prick. And I mean, I personally remove over a dozen unnecessary IV cannula placed just in my ED every single day that are put in by nurses and paramedics because they think the patient will need them. They don't have any medication given. They just have venipuncture for bloods. Maybe they don't even need that. There's just so many, and there's huge amounts. And patients don't like having these IV lines. A massive amount of those are unnecessary. Blood tests in every ED attendance. The indication for troponin is presence of a chest. And there was a campaign called Nuts at the Austin Hospital where in 1 year they reduced from 800 coag screen tests per week, ordered mainly by interns, very junior doctors, to 500, saving $95,000. It paid for a researcher. And of course, blood cultures, help occasionally, but rarely help outside of undifferentiated, moderate or severe sepsis. And then the urine samples, and again, I've heard about some campaigns you got here of skip the dip, or what it is, but I've got there, stop taking the piss, or let's have a wee think. A urine culture costs $50, $60, $70. Doesn't need to be done on everyone with a bladder. An asymptomatic bacteriuria in the vast majority of people is not a disease. Another microbiological test. So the pickup rate of a feces sample is 5% for giving a causative organism. 95% it will not give a causative organism, and a magnitude less than that it will change treatment, unless, of course, the patient is extremely ill with dysentery or other explicit indications. Low specificity blood tests, low risk populations, like doing D-dimers in no pretest probability PE patients, starting that diagnostic cascade that can only cause harms to patients and delays in the system. And CT scans are sort of a special topic that we do in our profession a lot of, and I'll talk to shortly. And there's massive overutilization, of course, of antibiotics for viral upper respiratory tract infections, sinusitis, uncomplicated wounds causing allergy, and a massive surge in MDROs, multi-drug resistant organisms. So coamoxiclav or augmentin is not the only antibiotic. And I use the phrase, you need to put warm steaming manure into a wound on the face for it to get infected, as long as you've done adequate wound care. And the CRP is one of my favourite tests, and every time you do a CRP, a kitten dies. And it's not a measure of unwellness. The list goes on, and these are all the things that we're needing to try and reduce. Next slide, please. So to the special case of CT scans, and in their emergency medicine is sometimes described, well, it's a sock, but just to be sure, we better get a scan. And there's massive overutilization of CT scans. Now, I've done an informal audit of 150 patients that I've cancelled CT scans on. These are patients in my emergency department, and they've either been requested by junior doctors, or colleagues sometimes, or mandated by decision instruments, or strongly suggested and sent in by primary care docs for things like head injury, trauma, pulmonary emboli. And out of the 150, I've had one miss where 5 days later, a gentleman came in having had a concussion. He was still vomiting with headache 5 days later, and he had a slight pinprick of a punctate hemorrhage in his brain. Didn't change his management at all, but otherwise I'm following these up, and I'm not sending, and a lot of these are patients that fall on direct oral anticoagulants, that it's mandated that you scan them, and I'm not scanning them all. And I've moved away from the emphasis of the danger of radiation to the danger of the incidental OMA. Studies have shown a rate of up to 86% rate of incidental OMA in trauma pan scans at a rate of about 2.8 per person. One study had 80% of patients with a cold had radiological evidence of sinusitis, as written on the report. And of course, we all see on our CT scan reports clinical correlation required, but it's better if you don't do the scan. It's not indicated in the first instance. So there's all the cysts on the liver, kidney, ovary, nodules on the thyroid, adrenals, pituitary, gallstones, all these things that you find. Had to explain to a 15-year-old that we'd scanned, and she probably did warrant a scan. She'd flipped her BMX bike and landed on her head, been knocked out, was confused for some time afterward. She had a completely normal CT brain, but had a small nubbin of extra tissue in her pituitary, and then she was going to need a whole bunch of tests of all her hormones to make sure it was a non-functioning pituitary adenoma. I had to explain to her what a bitemporal hemianopia was. I explained to her, no, she doesn't have a brain tumor. She's got a small bit of extra tissue, something that she was going to take to her grave. And these are all the impacts that you don't necessarily think of when you do CT scans. So that the risks of CT scans in comparison to other activities is there, and we need to cut these negative pan scans. I get so frustrated when the trauma team just comes down, walks into the room, says pan scan, and walks out. And I'm not talking about the really seriously injured patients. I'm talking about a CT pan scan coming back with zero abnormality, not so much as a paper cut. So, and the fatal cancer risk for a child, it might be as little as 1 in 500, and obviously getting a lot less once they get older. But it's difficult, and pulmonary embolus is really, really difficult to diagnose. And differentiating every chest and abdominal pain is really difficult. But we've got to exercise reasonable care, act in good faith, discuss it with the patient, shared decision making. But we really, really need to do less. So yes, there was a comment in the chat about what they're learning, and I believe you've got the STARS program here that's strong in Canada, that's still making the medical students aware of the fact that less is sometimes more. But you're right, some of this entrenched dogma is out there. Talk about the dogma of putting every dog bite on antibiotics. In fact, you don't need to put every single dog bite on antibiotics. Minor ones, not the more significant ones do. So yeah, the dogma is still out there and it's still being taught. But I would again congratulate Canada on your STARS program as being very good, because we've got to start very early. Next slide, please. So this is a woman who had breast cancer. She had, I believe it was 3 operations for her breast cancer, and she's lying there in the middle of all the PPE that was used in her 3 operations. It's really quite a spectacular amount. We're just absolutely addicted to plastic, addicted to PPE. And the unhealthy relationship with PPE started with the HIV epidemic, and then it moved to prions, which that we're absolutely paranoid about, but still don't seem to be causing significant illness. And then, of course, COVID has driven this absolutely massively. Again, just seeing a comment coming up about that medical legal risk. And again, we'll perhaps park that to the end and discuss medical legal risks because I work in a non-litigious country. You cannot get sued in my country. You can get the trouble for making mistakes and go through legal systems, but you cannot get sued, which is quite different, I believe, to certainly North America. But anyway, so just flipping back to PPE. And again, you see that slide there, and you'll all have seen the slide of here is the PPE used for 1 cataract operation in North America or Australia, and that's compared to the side to 60 cataract operations being done in India, and they're about the same. So we just have this incredible love of PPE, and now, of course, the environment and our bodies are all choked with microplastics. Next slide, please. So hopefully you've all heard of this campaign, Gloves Off, the environmental impact of single-use non-sterile gloves. So on average, 30 pairs of gloves are used per patient in a 12-hour shift in an Australian or New Zealand intensive care unit. A typical hospital ward with 32 beds, this is Australian statistics, uses 30,000 non-sterile gloves per month. That's 360,000 gloves per year. and plastics used in healthcare organisations contribute significantly to increasing environmental costs. And a third of the waste generated in healthcare is single-use plastics, including gloves. So hopefully you all know from those signs there that you use gloves for contaminated body fluid contact, non-intact skin, mucous membranes contact, and contaminated waste or linen surface contacts, but not for IM or subcutaneous injections, just touching patients, routine vital signs, dealing with intact skin. And research shows quite clearly that hand hygiene is worse when people use sterile gloves. So again, if everybody's concerned about their 5 moments of hand hygiene, don't use the gloves, do the hand hygiene properly. How are we going for time?
Maybe 5 more minutes.
Okay, so yeah, look, I'm nearly there. Antimicrobial stewardship, we've talked a little bit about. You go hard early in sepsis, and this has been driven, unfortunately, a significant amount of overuse as well. And remember the special case of Indigenous populations and the incessant rise of MDROs. And allergic reactions such as allergies. We challenge a lot of these, and some of them are caused, obviously every kid that gets penicillin or amoxicillin for their viral illness will end up with a viral rash, and it's thought to be allergy. And you get so many people coming in saying, oh, I'm allergic to penicillin. Oh, yes, I have. It was 30 years ago. My grandmother told me I came out in a rash. And so we now use the PENFAST rule of if it's more than 5 years since reaction, it wasn't severe anaphylaxis or angioedema, didn't require treatment, it's probably not an allergy. And I challenge that every day. Next slide, please. I probably don't really need to dwell on this slide. You know these more is not always better slides. It's really, really important that we don't necessarily need to do CT scans for all our chests and abdomens and troponins and do 1 million tests on every patient with shortness of breath, trauma. But again, remember the equity issue. And I've got there Miles' law, which is where you sit depends on where you stand, and it's about perspective. So to a cardiologist, a lot of people have ACS. To an orthopod, everyone's got a missed cervical spine fracture. And in emergency medicine, we spend our days looking at haystacks and finding occasional needles. And a lot of people find spending their days looking at needles. And the brand questions I've got there, and again, hopefully you know these. What are the potential or chances of benefit of this TTP? What are the risks of having this TTP? Are there simpler alternatives or options? And what if I do nothing, or what if I defer? Next slide, please. So I'm a little scared for healthcare, and I think medicine's much vaunted ability to help the sick and injured may soon be outstripped by the propensity to harm the healthy. You hear about the jumbo jet crashing every day, referring to preventable medical errors. That was coined over a decade ago, but I'd suggest it might be more accurately described to the complications of inappropriate healthcare. And are we just being incredibly selfish, transferring all our risk? I'll do a CT scan, hand it on to the next shift, hand it on to the patient. The patient can take all the risk, and I can't risk missing anything. One missed slightly, significant CT finding in 150 patients in my CT scan audit, and I think that is at best lazy, at worst selfish. And that defensive approach of trying to rule out every possible sinister cause, every possible patient, every time you see them, is simply not good medical practice. So perhaps we'll talk a little about the medical legal risk shortly. And so remember, primum non nocere, first do no harm. So next slide, just in the home stretch. In the words of Greta Thunberg, who's our Swedish, you can read there, we've all got a choice, and perhaps we do need to panic and act and feel like we would act as if we're in a crisis, act as if our house is on fire, because it is. And I wonder whether healthcare is on fire. So final slide. We need to stop the harm, stop the unnecessary care, and just say no and less is better. Be wise resource stewards, rationalize equitable care to those who really need it. Let's choose wisely and save the 3 P's: people, equity, profit, economy, and let's save the planet at the same time. Thank you.
Thank you, John. There are a lot of comments in the chat box. Maybe I'll just respond a little bit for the Canadian audience about the medical legal situation. just to say that we have worked with the Canadian Medical Protective Association, who's reviewed their claims, and they have told us probably about 2 years ago now that they don't see any claims for following the choosing wisely rules, that in fact they see those as standard of practice. What they do see claims for are people who've ordered a test, there is an abnormal result, but the abnormal result is overlooked. So a routine test, and it came back abnormal, which you weren't expecting, and it gets overlooked. And that does lead to medical legal claims. But they actually think the choosing wisely statements are standard of care, and that following them is good medical practice. And so they don't see this as a risk, but actually good practice.
So I gave you that phrase about, ruling out everything in every patient every time is simply not good medical care, and it harms both the patients. And I talked a bit about selfishness, and I can't comment. I don't practice in North America, and you do need to be aware of your medical legal environment and be aware of what your peers are doing, and make sure your peers are alongside you, because most of us get judged by our peers. But just say, for example, a CT urogram, and again, you'll know that if you have a young person that you're pretty convinced has got the illness, a ureteric stone, and doesn't have a AAA, and the pain is gone, they've got microscopic hematuria, and you talk to them and you tell them, I think you've got this, your kidney function's fine, you look well, the pain's gone, you've got one of these. Remembering there's a whole swathe of people that don't even come to hospital with their kidney stone. They grin and bear it, and the pain goes away. But you have the discussion with your patient, you document the discussion with the patient, and then it becomes, I believe that sort of patient is not going to come back and complain if you turn back and have a kidney stone later. So look, it is, and the patients that fall on DOACs, that come back with subdural hemorrhage, again, I think you could argue for the first CT scan not going to show that subdural anyway. It's going to be the subdural is going to develop over 3 or 4 days, and you need to see. So I send them home with ironclad follow-up instructions, as long as they can follow them. If you get more confused, etc., etc. So yes, you do need to be worried about litigation, but remember, if you think you've got to rule out everything and every patient every time, you're actually causing harm, and I think patients won't like it. So shared decision making, again, principles of choosing wisely right across here.
John, I don't know if you want to go back to the question, and David Berman, I don't know if you want to speak to this issue of regeneration versus sustainability.
Yeah, I've got I can't chat because I'm not. I'm just going to pull up a slides that really talks well about that.
David, are you still on the line? Do you want to unmute?
Okay, I'm glad to. Yeah, so regeneration really is the default. Like if you have a wound, your body will regenerate as long as you don't keep rubbing crap into it. And I think you can say the same thing for a bioregion or a planet, that the planet will regenerate if we give it enough time, but we'll have to get the hell out of the way. So it's, I think medicine, healthcare in general, has a conundrum, as we have to provide the care at the same time, realizing that I remember when cross infection, I was a dentist, I'm a retired dentist. So when cross contamination became a real issue, suddenly we had to wrap each instrument separately, which we trebled our contribution to landfill at that moment. So this is regulations, mostly political. What if somebody somewhere, however improbably, got a cross infection from somebody else? Then that becomes a political issue for the entire profession. And so I'm thinking in just in those terms, and you've covered that very well, I think, John. But in terms of planetary regeneration, we are in a predicament. If you look at the Stockholm Institute's overshoot statistics, where you've got, of the 9 quantifiable limits to planetary coexistence with humans, we've overshot 7 of them. And so we have a major predicament that goes way beyond medicine. And as you say, these effects are going to multiply. If even a 1 meter rise in sea level, which is, I think, inevitable, that's going to huge amounts of climate migration, increase of northern spread of tropical diseases. We are witnessing the end of the world as we know it. I think almost everyone would agree with that. And now what are we going to transition into? So anyway, enough of a rant.
Well, yeah, it's okay. John, do you want to comment?
Yeah, so as I've got this great slide that well, unfortunately I can't show because it's on my laptop, that talks about this transition from what we're currently in, which is could be described as degenerative practice, and try to reduce fossil fuel usage and all those sort of climate impacts, and moving more into the quality and living systems. And so gone from conventional care to green, designing systems, to sustainable, to restorative, to regenerative. So that's the journey forward in future. We're actually not just trying to stop doing the wasteful things that we do, and trying to do much more significantly positive things. So I do agree with that statement that we need to potentially make sure, while we're talking about sustainability, that talks about status quo, but we need to move positively forward. So thank you for your comments, David.
John, I think it would be interesting for the audience to hear a little bit about what you think public attitudes are in New Zealand and Australia, because I would say, looking around the room, some Canadians and subgroups of Canadians, like younger people, have this on their, they're concerned about it. But for many Canadians, it's like still a distant problem, and they're not really sure. And then we even have climate skeptics. So what's the public attitude like in your country?
I quite agree with that, and we would have that range in our country as well to a degree. And that's when I talk about levers to make people shift and move, and it's going to be slightly different in everybody. Whilst I passionately believe that we need to try and abate climate change and move more to more sustainable practice and stop this inevitable degradation that I've seen some presentations that are really, really super scary about cost. But everybody cares about something. And for me, I can use healthcare. And you can say, well, do you want to be harmed by healthcare? It's not necessarily the way you present that. And you've just got to try and find what motivates different people. Because I think everybody has their lever, whether it's about where they live, if it's about how well they are, and I think it all can filter through to the planet. So, our green parties have just suffered a little bit, and I think they have across a couple of different countries. Although the world geopolitical environment has been swayed by what's happening south of your border, fortunately, you in Canada and Australia have both had a significant swing, I believe, towards more liberal governments as a result of the election south of your border. But sometimes the green message gets a little bit sort of hidden. But again, people will have something that motivates them, that feeds up into ultimately saving the planet as well. And I'm using the healthcare one. And you talk to a lot of people about what I've talked about, and wasteful healthcare, and not having operations they don't need, not being on antibiotics. They all they have their light bulb moment. And so you've got to look at what motivates people, and it might not be voting for the Green Party and being a vegan, which is laudable clearly, and those sorts of things. So our attitude, I think I always think of the Canadians as being our cousins as well. We're very similar culturally, and we've always got on. And I think politically, Canada, Australia have just aligned slightly in government. So hopefully similar. I don't think there's many complete climate deniers anymore. There will be. There's vaccine deniers, there's climate deniers, but I think they're starting to be the lone person rocking back and forth in the corner of the room in a trench coat saying the end is nigh.
Okay, there's a comment about virtual care, and I know this is something of interest to you.
It is.
So Julie Nordstrom says, virtual care and no hospital visits would help save the environment for some patients' needs. So I know this is of interest to you, John.
100%, I can talk to that. Thank you very much for posing the question. So I do two jobs. I work full-time in an emergency department, and my other job I work about 3/4 time doing telehealth. I think telehealth is a powerful equity tool. You use it extensively in Canada. Equity as in healthcare delivery for people that don't usually have access. Virtual care, telehealth, I think is critically important. And as you allude to, keeping people out of the big expensive hospitals where they arrive in the emergency department, their arm goes out, the IV line goes in, the blood tests get done, the PAN scan gets ordered because of the inefficiencies in their system. So you are so right. Telehealth cannot replace. We need people in rural settings. So my telehealth organisation supports rural hospitals. We jump into ambulances for their kind of code orange patients. The code red, that's really the ones they take straight to hospital. The green, not unwell ones, they leave, and we jump in and help the paramedics decision make to again keep people out of hospital. And did an audit of 6,000 ambulance calls for this sort of patient. 80% kept at home. And out of hospital, where previously they would have been taken direct to hospital because the practice guidelines mandated. So 100%, as long as you don't think that you can run rural Canada and Australia and New Zealand purely by telehealth, you need people in these places as well. They can augment support and help, and it's completely, I think, part of saving the planet, keeping people out of hospitals. And I get so much positivity from the people I consult by this manner. They think, oh, this is so easy. It's just, I'm getting some of them. It's healthcare in their home, but some of it's in rural hospitals. So yes, I would acknowledge that and agree.
I'm mindful of time. I want to just give you a last moment to close, or anybody in the room that wants to make any other comments. Okay, then John,
So,
give me the last word here.
Thank you very much for coming to listen. Hopefully, a lot of what I said was things that you already know. That's just a little bit of a slice of my world in New Zealand and Australia. Let's call ourselves cousins, and we can build and work together to save our patients and save healthcare, and a side effect of that, saving the planet. Thank you very much.
Thank you very much, and thank you for your comments. I know there are more comments coming in, but I think I'll bring this to a close and appreciate everybody attending. Let's see, just the last comment. We have an upcoming Choosing Wisely talk called Ask Why for PPIs, and we'll be releasing a new toolkit at that time on decreasing the use of PPIs. So please join us. And if you aren't already but want to come to Winnipeg, we have our national meeting next Monday and Tuesday in Winnipeg. So we look forward to seeing some of you there or seeing you online for the keynotes. And thank you, everybody. Thanks for participating.